Okay, so welcome to this Zoom session. Actually, it's really not a session and it isn't on Zoom, but you know what I mean. I am sorry that I had to cancel the Sunday session with you lot. Something came up and I couldn't do much about it. So, in order to try and make up for that, I'm going to talk to you about central and bilateral back pain and why it's a very if not a warning sign, then certainly a precautionary sign to you doing manipulation, or indeed very much with this patient without getting a good deal of investigation done before you get too aggressive with it. Bilateral back pain, bilateral leg pain, both of them carry dangers, and we'll look at this. So the first slide that I want to look at is basically central low back pain plus or minus leg pain, the little purplish square in the middle. And what we've got here is a number of possible diagnoses. I don't know if you can see the cursor or not. We've got a contained disc herniation, an uncontained disc herniation, spondyl fractures, stress fractures, and pathological fractures, and I'll touch on overt fractures, but really they don't need an awful lot. They're not that difficult to sort out. And of course, spondylolisthesis. All of these have central pain, and which may then go bilaterally down both legs. These are the ones you really want to be careful of. So if you think about a contained disc herniation first, this is not what you first think of when you think of a disc herniation. This is not externalization of the disc material. Rather, this is an internalization of the disc, or at least the nucleus of the disc. So this seeps out through the annulus, and it's believed one way that this can occur is that the nucleus becomes introduced to the blood supply, basically. And this may be via a vertical herniation into the end plate or even into the disc when it becomes a Schwell's node. But either the end plate or the disc will allow the blood system to actually contact the nucleus, and the nucleus doesn't like blood. Blood is very toxic to it, and it degenerates fairly rapidly. Now, these tend to occur in childhood. They're often traumas, falls onto the butt from a tree, but some form of trauma that results in central back pain. The patient may or may not remember this because it takes a while for this nucleus to actually migrate through the annulus. And actually come into contact with the nociceptive portions of the annulus, the outer third of the annulus. So generally speaking, the first symptoms are felt, when they are felt, and not all of these are symptomatic, but the first symptoms when they are felt are around about 28, 30 years of age. And basically it's after a few years of degeneration of the disc where we start seeing the separation of the lamellae with horizontal clefting, basically separation of the lamellae, but without the organized radial tearing of this thing, but where they do separate. And then it works its way into these clefts and oozes, if you like, seeps between the annulae and migrates outwards. And it's when it comes into the contact with the outer third of the annulus that it starts becoming or can become nociceptive. And often there's a trigger for that to occur. A long car ride, doing labouring, whatever it is, something unusual. And this will usually set up the back pain. Now, the way the back pain is felt is generally central, although if there is already radial tearing, that oozing of the nucleus will go through the easiest way, and it will go through that radial tear, and then that may well then become a hernia, a proper uncontained herniated disc. But generally speaking, these things are contained by the annulus. It's neither a prolapse nor an extrusion. It's contained by the annulus, and it doesn't even really cause any bulging of the annulus. So this is pure discogenic pain. This isn't compression of the dura or the nerve. This is purely pain from the disc itself that's in trouble. So you'll see this is spreading. As I say, there's usually a trigger for it. and the pain will start off and then start to radialize more. So it will be felt across the back, into the buttocks, down the legs. One leg is often worse than the other because this is symmetrical seepage, really. So it gets basically one side is generally worse than the other. They have trouble, as with all discs, they have trouble with extension activities and flexion activities. They're more comfortable in laying. Everything else tends to bother them, bending, walking, and so on. So it behaves very much like a disc, but this progresses and it keeps on getting worse and worse and worse. The straight leg raises, on the other hand, are essentially negative. There may be some pain near the end of the straight leg raise as you start to flex the spine, but the straight leg raise itself as a dural test is negative, and neck flexion generally doesn't add anything to the positiveness of the straight leg raise. These things are difficult to treat. Once they're diagnosed, and they are diagnosed definitively by a discogram. The discogram does two things. It images the migration of the nucleus, but at the same time it also increases the pressure inside the disc and it reproduces the patient's pain. So you can get these things occurring that are not painful, in which case the discogram will show it, but there'll be no pain associated with it. But when they are symptomatic, this will also increase pain. What's interesting was there was a study done with an electric toothbrush and a CT scan, and no injection into the disc. What they found was the CT scan could image the herniation, and the electric toothpaste brush, when it's vibrating, placed on the spinous process of one of the bones involved in that segment, will reproduce the patient's pain. And this type of testing was almost as good as the discogram, but without the added problem of actually injecting a dye into the disc and increasing the risk of further degradation of that disc. So these are very difficult to treat. If it gets bad enough, they'll actually take the disc out and cage the segment so it essentially is fused. A newer treatment is intradiscal endothermy, where they'll insert a wire into the outside of the disc and then put an electric current through it, and it will raise the temperature of the disc by about 3 degrees or so. And that and maybe another repeat session of it will often decrease or eliminate the patient's pain. Now, how it does this is arguable, whether it destroys the nociceptors or it just changes the characteristics of the nuclear material that's also degraded at this point. I don't know that anybody really knows, but it can work quite well. When it doesn't work, it tends, I believe, to be caused by a misdiagnosis. And the ones where it doesn't work is on older patients. And as I say, these usually come to light about late 20s to 30. So anything much older than 40 and 45 is probably not this condition, which may explain why it doesn't work. Differential diagnosis, pretty much anything that will cause central back pain. So you have to, the determining characteristics are whether or not that pain affects all movements, flexion and extension activities, if it is progressive or if it's not, if it's episodic or if it isn't. So, and how sudden the onset was. So things like stress fractures, pathological fractures have a fairly sudden onset, so they will be eliminated from the diagnosis. Median disc herniations will affect the dura quite badly and often the neural tissues, so you'd expect to see neurological signs which you wouldn't see with a contained disc herniation. And very limited straight leg raise, unless the cauda equina syndrome is so bad that the disc herniation has basically desensitized them. But at that point, there's not really a problem saying that this is a median disc herniation. Okay, so let's move from there and we'll move on to an uncontained median disc herniation or paramedian disc herniation, where the disc has gone either straight backwards or back and off to one side, but still enough to hit central tissues. So if we move outwards, the essential illness script gives you severe back pain, the same as it just did. There may or may not, and probably will be, neuropathic pain, or at least neuropathic symptoms such as paresthesia. You expect to see radiculopathies, multiple radiculopathies, which is really what this is, or if you prefer to think of it in other terms, of cauda-equina distributed weakness, sensory loss, and reflex changes. If this starts getting down to S4, there may be bladder, and it's bad enough, there may be bladder and bowel changes as well as those sphincters become affected. Certainly now, the straight leg raise will be seriously affected, and range and neck flexion will make this a lot worse, unless, as I say, the lesion is so bad that it's desensitized the neuro. But at this point, this isn't a diagnostic dilemma at all. So what else can this be? A contained disc herniation, which we just discussed, and of course spondylolisthesis, because spondylolisthesis, if it's bad enough, will cause a cauda-equina syndrome. And it's going to be a little difficult for you to sort these out, but honestly, does it really matter? If you've got multiple dermatomes involved, multiple myotomes involved, and you're thinking that it's a cauda-equina syndrome, it really doesn't matter what's causing it. This really does need to get to the emergency room, not even the physician's office, but the emergency room. So it needs to be investigated in more detail than you can possibly do. Moving down, stress and pathological fractures. Let's look at the overt fracture first. This is going to show up as a major trauma, severe onset of pain, and sudden severe onset of pain at that. These people are completely messed up. They can't bend forwards, they can't bend backwards, they can't walk, they can't do very much at all. This is not likely to come into your clinic. If it does, though, recognise it for what it is. It's a very stoic person who didn't go to the emergency room when they broke their back. There may or may not be neurological consequences. If it's a compression fracture, probably not. Now, as far as pathological fractures are concerned, this is going to occur in the older patients because of osteoporosis and other degenerative conditions that will weaken the bone. So this pain is unlikely to be as bad as the overt fracture. The force of the trauma is not going to be very high at all. And this is one that can be missed because of the lack of trauma. Now, given this is an older patient, it's very easy to put this down to spinal stenosis, just based on the patient's age. Please don't do that. The age is a predisposing factor, but it should not be an active factor when you're trying to diagnose this. There'll be a lot of tenderness on palpation. So when you try and do a PA, you'll get a very unusual response, which is not what you see with stenosis. So go further than stereotyping the patient based on their age, and particularly age and sex. You've also got, of course, not just osteoporosis, having trouble here, but secondary carcinomas. So these all weaken the bone, and away it goes. With the stress fractures, you expect a history of severe overactivity. These are usually younger. If it's a woman, then there's generally some nutritional problems going on here as well. They may be anorexic or bulimic. Have a look at their teeth, see if they are bulimic, and the teeth look a bit messed up as the acids erode the enamel. If you can look at the teeth, do so. The type of activities are kicking sports. Now, this may be just off centre now, but it may, if it's bad enough, pain's bad enough, it will still radiate across both sides. But if it's a little off centre, this may be what used to be called a laminar sprain, but it's actually it is a fracture of the lamina and the pedicles, and this often occurs with kicking sports such as football. But it's all about overactivity and undernourishment. With a female athlete, it's well worth talking about their periods and if they're still having them or not. Degenerative diagnosis the degenerative diagnosis is likely to be a juvenile spondylolisthesis. The difference between the two is that the spondylolisthesis tends not to be of a gradual onset, and it can be on and off, whereas the fracture is a very gradual onset, bang, and that's a major difference. Either one of these two, though, needs imaging. Okay, and then moving on to spondylolisthesis itself. Basically, two types. Let's move me. Essentially, two types. Adolescent, which is probably congenital, it may be traumatic, but it's probably congenital. Ages of 14 to 18 years old, these tend to be really very bad. So there's a severe pain with an ache. There's often neurological involvement, and you may see just one level affected, or it may be a cauda equina problem, but there's probably going to be neuropathic pain. Certainly neuropathic symptoms such as paresthesia, extension activities and postures are going to be a real problem here. PAs will be extremely positive. You may be able to pick up a step deformity. They try to be kyphotic to bring it forwards, and again, this really does need imaging. Degenerative types over 40 years of age. It's often a woman for some reason. They tend to be a little bit obese, and again, it's less likely to have neuropathic symptoms than the adolescent. The pain is usually less severe. The problem is mostly on prolonged stand. It may also be walking. If they flex their spine, it tends to help it. It's relieved by sitting, and there may or may not be a step deformity, but again, PAs are positive. And your diagnosis for these are a median, paramedian disc herniation. And again, it needs imaging. Don't mess with this too much. There may or may not be a neurological symptoms with these. If there are, it definitely needs imaging. Okay, so the one I left out, sorry, I'm going to come back to it, is from the adolescent spondylolisthesis. Overt fractures if they're active, but that's a telltale difference, it's the activity. Although it's worth saying that female gymnasts will get a traumatic spondylolisthesis. It's gradual, but nonetheless it is traumatic rather than congenital. And it may be a very atypical median disc herniation. It doesn't honestly matter though, because it still needs imaging. So as you can see from this slide, there's really not much here that you want to treat manually. And actually with a lot of this stuff, you shouldn't be touching them at all unless it's been properly diagnosed. So just one more slide and we'll be done. This is about serious pathologies for the most part. So I'm going to move me again. The only reason I'm keeping my image on here is because I know how reassuring you find my face. So if we're looking at more serious pathologies, if we come onto the right side here, we've got the forbidden area of pain. Now this is a strip of skin about level with L1, L2, so it's below the thorax and above the mid-lumbar spine. Difficult to tell exactly where this is, but it's somewhere in that region. The problem you've got is that thoracolumbar lesions are really quite common. So you can fairly easily mess this up, and it's not something you go, oh, look where the pain is, I've got to get this sorted out. This just says to you, actually, this could be forbidden area pain, and we need to have a closer look at it than I would do if this was a bit higher or a bit lower, with a more skeptical eye. The forbidden area was a concept that was brought in by Syriac. It's quite a good one. The reason that he had concerns about this is because L1, L2 is the area where secondary deposits from carcinomas tend to go in the lumbar spine. It doesn't bother the lower parts too much. Even the lower thoracic gets missed, but L1, L2 tends to absorb it. It may have something to do with the watershed area. But this is why. And in fact, central pain at this level is probably as equally caused by tumours as it is by anything else. And at least that's the way you really want to look at it. So I don't think, unless it's got a very, very clear history of biomechanical dysfunction, and that is unusual with a central back pain, unless it's got a clear history of a biomechanical dysfunction, you really want to mess with this too much, and it probably should be imaged. Your problem is going to be convincing the physician of that. So as I say, you assume that it's serious pathology. You can look at the bones, do PAs on it. You can do tuning forks to see if you can aggravate it with that. If you've got an electric toothbrush around, use that and see what happens. Okay, but it needs to be referred out. Okay, so severe bilateral back and leg pain. We've talked about this on the previous slides, but it could be an acute spondylolisthesis, or it could be a median or paramedian disc herniation. And again, this needs to be carefully checked by you, and it needs to be referred out. Not necessarily. If there are neurological symptoms with either of these, refer it to the emergency room, not back to the physician who sent it to you, or the physician whose patient this is. It probably should go to the emergency room if there are bilateral neurological signs and symptoms. Okay, moving along to that way. Moderate severe sudden onset of central low back pain. Age greater than 55. Pathological fractures. That's what you need to keep in your head. Pathological fractures. The trauma may well be fairly minor, but it doesn't take much if you haven't got a lot of bone left to break it. So anybody over 55 with a sudden onset of severe pain, the chance of being a disc herniation in an older patient isn't very much. But either way, if this is now a disc herniation and it's under 55, then you need to be on your toes about this one as well. So, age over 55, pathological fracture. It doesn't take much, as I say. Again, fire it off for imaging and see if the patient comes back to you. Severe buttock pain with or without thigh pain. Okay, bilateral or unilateral. If it's a young adult or a middle-aged adult, think of sacroiliitis. Now, in a young adult, you may well be thinking, especially if it's a young man, you may well be thinking of ankylosing spondylitis. If it's a middle-aged person, you probably are looking at something akin to sacroiliitis, but more, not necessarily correctly, but as far as the differentiation term is concerned, it's better, is a reactive arthritis as part of Reiter's disease or Crohn's disease, but it can also be from things like psoriatic arthritis or enteric arthritis. So look for positive folding signs and antalgic gait. The big one here with inflammation in this joint is turning over in bed, a sudden sharp pain that wakes them up. You may find other joints or other systemic effects, enthesitis, so they have tendinitis, fasciitis, and so on. You can look at their ribs, like very careful springing of the ribs, and I do stress it's very careful springing of the ribs. If the ribs are not very springy, they may well be stiff and the ribs may be infected. If you push on this too hard, you may fracture, which is why I say careful springing. You can also measure expansion of the ribs. A young adult, even a middle-aged adult, you should be getting 1.5 inches, 2 inches of expansion. And if this is a major athlete doing a lot of training and a lot of heavy work, it should be a lot more than 2 inches of expansion, or 5 centimeters, I guess. Anyway, back to the physician for more definitive diagnosis, blood tests, and so on. Okay, unilateral back pain. Let's get rid of me again. Over here. I find that disconcerting when I see the gap underneath me, I'm sorry. Unilateral back pain. Okay, well, there's lots of causes for this, but we're looking at reasons why you may be thinking this is not good. First episode in a patient over 50 without any major triggers. So this is the age when secondary disease comes into play, tumors, pathological fractures, and so on. You're looking for it not to be a typical presentation of a segmental dysfunction. So we're looking for it to be non-episodic, more severe pain, more severe radiation and referral, obligate functional loss, and so on. So when it doesn't fit, you've got two of those things in trouble, then I think probably it's worthwhile referring this out to the physician. Okay, and then central low back pain with iliac fossa plane. you've got to be thinking viscera now. So this pain is in the front of the pelvis. So you've got to be thinking this is, so you're looking for organ pain, deep, dull, diffuse pain. It may well start off centrally and then localize to one side. So it spreads across and then localize as time goes on. It tends to come in waves. It's really not terribly related to general activity, flexion or extension. In fact, general activity may relieve this. You can see the same thing I'm talking about. This can occur in the back, in the front, in the abdomen, in the iliac fossa, and it is referred pain, but you really don't want to be thinking of this as referred from the spine. The real problem with this one is that the organs tend to be a deep, dull, diffuse type of pain, whereas the linings of the organ, the peritoneum, pleura and pericardium, all of those linings tend to be more musculoskeletal in type, and this is because these structures have a lot of nociceptors, the linings, loads of nociceptors, myelinated fibers subserving them, whereas the organs tend to have fairly sparsely innervated and unmyelinated fibers subserving those. So if you're seeing these types of pain, get it off to the physician. And it's unusual to see abdominal pain that isn't coming from the abdomen, especially if the back isn't a problem. Okay, so I hope this helped, and hope it makes up a bit for not seeing you tomorrow. So